Good morning, everybody. So today morning we are going to talk about briefly about the clinical aspects of enteric fever, right? So this is going to be a short talk in which I'm going to highlight from the medicine point of view what are the important aspects of enteric fever, right? So the enteric fever is a synonym for the word typhoid fever, and it is called typhoid fever because of its clinical similarity to another infection, a rickettsial infection called typhus. So just like typhus, it's typhoid fever. Typhoid fever was clearly defined pathologically as unique illness on the basis of its association with enlarged Peyer's patches and mesenteric lymph nodes. So we would see briefly in the pathogenesis, typhoid fever happens through the agency of inflammation of the Peyer's patches and mesenteric lymph nodes. This is one of the pathological hallmark of the disease typhoid fever. So in 1869, the term enteric fever was proposed because it was thought that it is a better terminology because वो audible है? Okay. So the term enteric fever was proposed as an alternative to typhoid fever because it was thought that since the disease starts off in the intestine or the enteric system, it would be a better term. But it would be important to remember that both the term typhoid fever and enteric fever, they are used interchangeably. So it is a disease which is caused by Salmonella enterica serotype typhi. So I'm sure that you guys must be knowing this from your microbiology classes. The term typhoid fever or enteric fever also refers to the infection caused by an associated organism called the Salmonella paratyphi, which is divided into three serotypes A, B and C, A being the most common. Now microbiologically it is a gram-negative bacilli, non-spore forming, anaerobic facultative anaerobes, and it belongs to the family Enterobacteriaceae, and it typically happens in patients in people coming from poor socioeconomic background where there is a problem of poor sanitation and crowding. So it is mostly a disease of the developing world. In developed world, USA, Europe, this isn't seen much. So in India can be said to be the typhoid capital of the world, has the maximum number of cases globally, followed by other South Asian countries like Pakistan, Nepal, so on and so forth. So this is briefly about the bacteria. So it would be important to remember that there are three types of antigens, namely the H, the flagellar antigen, the polysaccharide antigen, and the O, the somatic antigen. Now the H and the O, they are also used during the Vidal test, so it would be important to remember this when we discuss about the Vidal test subsequently. So as I said, that this is mainly a problem of the developing world due to clean water and good sewage system. Europe and USA they see cases in hundreds per year, while India it sees cases in lakhs, and it remains a serious public health problem in developing countries. How is it transmitted? Well, that's very intuitive. Since the pathology happens mainly in the gut, so people are the natural host. So it is mainly transmitted by the fecal-oral route, and people are the human beings are the natural host and reservoir for Salmonella typhi. So this doesn't happen in any known animal. So this has been a ground for consideration of eradication of this infection, since it happens only in humans. The humans are the only carriers, but that has been problematic given the fact that the main hurdles are being poor sanitation and poor socioeconomic background. So that needs to be tackled first before we can even think about eradicating Salmonella typhi. The pathogen, they can survive for days in groundwater, pond water, sea water. So the infectious dose, it would be, if you can remember it, it's somewhere between 10 to the power of 3 to 10 to the power of 6 million organisms given orally, And as I said, it is typically transmitted by ingestion of food or water contaminated with feces. Established risk factors being contaminated water supply, eating ice cream, flavored ice drinks, or food from street vendors. So, if you guys fancy golgappas and stuff like that, which are probably not prepared that hygienically, so this may be a real problem. In fact, I think annually I see at least 10-15 people, either staff or students, who come with a diagnosis of enteric fever. So it is pretty common even in our scenario. And as far as food they are concerned, which can lead to transmission, raw fruit and vegetables grown in fields fertilized with sewage, cauliflower, if they're not cooked properly, if they're not washed properly, they can act as sources of transmission of the enteric fever. Now, around 10% of people recovering from untreated typhoid fever, they may excrete Salmonella typhi in the stool for at least 3 months. So they are carriers. They are temporary carriers. For 3 months, 10% they may excrete Salmonella typhi. However, the number dwindles to between 1 to 4 or 5% who became chronic carriers. So, which is defined as excretion of Salmonella typhi in urine or stools for more than 1 year. It has been seen that rate is higher in female gender, elderly people, those with schistosomiasis, cholelithiasis, some problem with the gallbladder like carcinoma, and other GI malignancies. Most chronic carriers are asymptomatic. So if you remember, we used to read in our microbiology textbooks about typhoid Mary, the lady who used to work as a cook and who had led to the infection of a significant proportion of individuals for which she cooked, so either in restaurants or houses. So the name Typhoid Mary became iconic and became symbolic of the fact that typhoid carriers, they are potential threats to public health. Now the pathogenesis, as I said, so somewhere between 10 to the power 3 to 10 to the power 6 organisms commonly, when they are inoculated, they enter the stomach. Now normally we have the gastric acidity which takes care of the organisms, but however in conditions, say use of antacids, infection by H. pylori which may predispose to a chlorhydria, these organisms might proliferate. They may invade the Peyer's patches, multiply in mesenteric lymph nodes, and from the lymph nodes they may enter into the bloodstream, causing transient bacteremia. Now these transient bacteremia, they lead to seeding of these organisms into various organs. Typically they enter the reticular endothelial system, which leads to the disease proper, right? Now from the reticular endothelial system, they might also enter the bacterial stream again, causing another round of bacteremia. Typically, pathologically what is seen is hyperplasia of the Peyer's patches, necrosis and sloughing of the overlying epithelium, intestinal ulcers, and typically the ulcer heals without scarring, thus strictures and nasal obstruction virtually never occur. So if you remember, typhoid stands for the tie that is longitudinal. So the ulcers, they are typically longitudinal ulcers. So this is the gut wall, the longitudinal ulcers. When they fibrose, they do not cause stricture like this. So they are longitudinally placed. So no strictures are seen in typhoid. You can compare that with tuberculosis, where typically strictures are more common. And there might be focal inflammation in the form of abscess, septic arthritis, osteomyelitis, pyelonephritis, meningitis, and endophthalmitis. Coming to the clinical presentation proper, after ingestion, the typical incubation period is for around 1 or 2 weeks, and the onset is typically insidious. Typically, the symptoms develop over 4 weeks, with new symptoms appearing each week, but with rapid treatment, the symptoms they usually improve quickly. So what happens? So we'll just try to see the clinical presentation of the symptoms occurring according to the stage. So the initial stage, that is early stage due to bacteremia, generally it is the symptoms are non-specific, lassitude, myalgia, insidious onset of fever. Typically the fever rises in a step-ladder fashion for 4 or 5 days, with, as I said, malaise, headache, drowsiness, aching in the limbs, abdominal pain, and diarrhea or constipation might also happen. So enteric fever, again as the name suggests, it is from the it involves the enteric system. So abdominal symptoms, they are typically present in the form of abdominal pain, diarrhea, constipation. In the second and third weeks, generally the fever it picks up. So the patient might appear more toxic, anorexic, might have significant weight loss. The conjunctiva might be red, and the patient might have tachypnea with low volume pulse and crackles over the lung bases. Abdominal distension may be severe, and the patient might have something called a typhoid state, where it is characterized by apathy, confusion, and even psychosis. So typically a word, a phrase is used, coma vigil, where the patient appears to be he otherwise appears to be aware of his surroundings, but he does not respond to any external stimuli. So he is appears to be in a coma, but though apparently exteriorly it might appear that he is just normal, he is just looking around. In the second and the third weeks, again, there might be the most dreaded complication of bowel perforation and peritonitis, and typically this occurs when the patients are given steroids. And if perforation and peritonitis happen, usually the patients are very severely ill. They have toxemia, myocarditis. They might even have intestinal hemorrhage, and there might even be mortality. So some of the typical signs and symptoms. There is relative bradycardia. Relative bradycardia, remember that for every degree Fahrenheit increase in temperature, there's usually an increase in the pulse rate by 10. So if that is not happening, then that is what is called a relative bradycardia. It is thought to be due to the action of the toxins on the heart conducting system. There might be hepatosplenomegaly, rose spots, typically seen in fair individuals, where there is a faint, pale colored, slightly raised maculopapular rash. They typically happen in the first week and they disappear. So rarely do we see patients coming with rose spots, because by the time they present to us, the rose spots they have typically disappeared. And by the fourth week of infection, it is usually called the defervescent stage. So if the individual survives, the fever, mental state, and the abdominal distension, they slowly improve, though the patient might still have some amount of intestinal or neurological complications. Some survivors, as I said, between 1 to 5% of patients, they might become asymptomatic carriers, and they have the potential to transmit the bacteria indefinitely. So the defervescent stage is followed by the convalescent stage in the 5th week, where there is disappearance of all symptoms, but they can relapse. So regarding the complications which I talked about, right, so these are the complications. They are divided according to the system. So orodental, there might be parotitis. Chest, there might be bronchitis, pneumonia, even infarction. Heart, there might be myocarditis. Hepatobiliary, fatty liver, hepatitis, abscess, cholecystitis, cholangitis, pancreatitis. The GIT, perforation, peritonitis, hemorrhage, they can be present. CNS encephalitis, meningitis, transverse myelitis, GB-like syndrome or transverse myelitis may be seen. Encephalopathy may be seen as well. And chronic osteomyelitis, arthritis, myositis may be seen, and uveitis has also been reported in association with enteric fever. So a little bit about the more important complications. So the intestinal hemorrhage, they commonly appear in the second, third week. They may be mild or they might be severe bleeding. So the serious bleeding typically occurs in around 5% of patients. How do you know it? So on a patient of typhoid fever who is having relative bradycardia, if there is a rise in pulse, or the patient becomes toxic and there is frank sign of shock, namely tachycardia, hypotension, cold, clammy limbs, and if it is associated with dark or fresh blood in the stool, then we have to suspect strongly about intestinal hemorrhage. Regarding intestinal perforation, this is more serious, though the incidence is less. So we can see the X-ray on the right, which is showing a gas under the diaphragm, right? So this is the right cupola, the left cupola. We can see the fundic gas here. We can see the liver here, and we can see a crescent of air, which is not supposed to be here. So if this air was within the gut, this would not have formed a crescent-like structure here, occupying the superiormost part in the abdomen in an erect patient. So if the air is appearing like this, then it means that the patient has intestinal perforation. This is a straight indication for emergency laparotomy, identification of the leak, sealing it, followed by medical therapy in the form of antibiotics. So the intestinal perforation typically, which is seen in 1 to 4%, they commonly appear in the second and the third week, and they typically occur at the lower end of the ileum. Before perforation, the patient might have manifestation of diarrhea, abdominal pain, intestinal bleeding, and as I said, the diagnosis of choice is a an erect abdominal X-ray where there is free air under the diaphragm. Toxic hepatitis might appear as well. So typically, it happens in the 1 to 3 weeks of symptom onset, and it is characterized by hepatomegaly. So clinically you will get hepatomegaly, and there will be transaminitis in the form of raised SGOT, SGPT. So usually the toxic hepatitis part, they improve within 2 to 3 weeks. Toxic myocarditis may be seen around the same mark, 2 to 3 weeks, and usually the patient is having severe toxemia. Myocarditis again is manifested by tachycardia, decreased blood pressure, and the patient would be again severely ill. Bronchitis, bronchopneumonia, just like other form of pneumonia, may be seen in the early stages, characterized by again cough with or without expectoration, and on examination there will be crepitations or crackles during auscultation. So that was about the symptoms. Briefly about the diagnosis. So other than a positive culture, no specific lab test is diagnostic for enteric fever. So this is important because many times we see patient coming with a Vidal report or an antigen, typhoid antigen or an antibody report, and saying that I have fever for 2 days, and look, this antigen is positive, this antibody is positive, so I am having enteric fever. Not only that, I am having enteric fever since the last 20 years. Every year I have enteric fever. What do I do? So the thing is, most definitive evidence of salmonella typhi or typhoid fever is a blood culture which may be positive between 40 to 80% of patients. Short of that, anything short of that, they are not definitive or conclusive evidence of salmonella typhi. If a patient has typhoid or is exposed to the organisms anytime during his life, he might have antibodies. So just the presence of antibodies doesn't mean that the patient is continuing to have enteric fever, and any fever in that patient may not be ascribed only to enteric fever. It might be something different. It might be seasonal flu, it might be dengue, it might be malaria. So we have to keep our eyes open, and any patient who comes with any other investigation short of a positive blood culture, we should be closely scrutinizing it before labeling it as a case of enteric fever. Now, the CBC in a patient of enteric fever, they typically show leukopenia, neutropenia. So this is a bacterial infection where leukocytosis is not seen. So normally in patients who are having bacterial infection like say meningitis, urosepsis, right, or infective endocarditis, they typically have increased counts, but here is a bacterial infection where we see leukopenia and neutropenia. Leukocytosis is more common among children. It might be seen in the first 7 days to 10 days, and in conditions where it is complicated by intestinal perforation or secondary infection, we typically see leukocytosis. So as I said, when a patient has intestinal perforation, the picture changes. We discussed about the patient from relative bradycardia may move to frank tachycardia. The patient who was not that sick becomes more sick. The patient might have typical features of shock, and the patient biochemically might also move from leukopenia, that is decreased WBC count, to leukocytosis, that is increased WBC count. So other non-specific lab findings may include elevated liver function tests, that increase AST, ALT, along with CPK might be raised. But again, the most definitive diagnosis is by the help of a positive culture. So culture. So where do we culture salmonella typhi from? Typically it is done from the blood. It may also be done from the bone marrow, the stool, and the intestinal secretions. Right. So typically, if you would remember the 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 acronym BASU, blood A for antibody, S for stool, U for urine. So this is according to the order in which the salmonella typhi they start becoming positive in the cultures. So the blood it is typically in the first week, antibody the viral it starts from the second week onwards, end of first week, second week, stool and urine they are in the third and the fourth week respectively. So what do we do for blood culture? It is just like any other culture. 5 to 10 ml blood is taken in broth. However, if you take larger volumes, which may be challenging because you have to take the blood for a number of investigations, so it might be difficult. So typically around 5 to 10 ml they are taken. If you take larger volume, the sensitivity is increased. The blood culture, as I said, has the best performance the first week, where it may be positive in around 90% of cases. In subsequent weeks, it might decrease from 90 to 75, 65, and 25% in the fourth week. So as I said, blood culture sensitivity is around 40 to 80% depending on which week it is. Now the blood culture sensitivity or the yield is decreased further in cases where antibiotic the patient receives antibiotics. So if there is administration of antibiotic, what happens is that those antibiotics in the blood would inhibit the growth of organisms. So the typhoid or the salmonella typhi they might remain confined to the reticular endothelial system and not be there in the bloodstream. So the yield of a blood culture may be low, and it might be also due to the fact that a small portion of the salmonella typhi they are present in the blood. Most, again as I was saying, they are lodged in the reticular endothelial system. So the blood culture again as a tool is very specific, but its sensitivity may be as low as 40%. The bone marrow culture it may be better, it may be positive in 55 to 90% of cases, and unlike blood culture which is affected by antibiotic, this is not affected by antibiotic because again bone marrow is a part of the reticular endothelial system. So the antibiotic does not have much effect on the growth of organisms in the bone marrow. So it is a good medium for culture of salmonella typhi. Now the culture of the intestinal secretions, which can be obtained by a number of methods, endoscopic or duodenal string method, they can be positive despite a negative bone marrow culture. So but then again, intestinal secretion aspirations is not commonly done. However, if we choose to do all blood, bone marrow and intestinal secretion, usually the yield is increased and it is typically to the tune of more than 90%. Stool cultures, while negative in 60 to 70% of the cases, that is it is positive in 30-40% of cases during the first week, but they can become positive in the third week of infection in untreated patients. So the BASU, if you remember, S is in third place. So the third week the stool culture yield increases, it becomes around 50 to 60%. Now this a little bit about the viral test. So this is actually a test this is actually a serological test which is used to measure the antibodies, the agglutinins, which typically rise during the second or the third week. This typically detects O and the each antigens. O antigen is common for typhi and paratyphi. Each antigens they differ, and typically two serum specimens they are obtained at intervals of 7 to 10 days apart to read the rise of antibodies. So typically the viral test is not usually taken as a standalone test to diagnose the case of enteric fever. So normally if we are suspecting a patient to be having enteric fever and if we are doing viral test, then what we do is that after doing a viral test we see the titer and we repeat the test after 7 days. So if it is an acute infection, the titers they are going to vary. Typically the titers would increase when it is repeated in the next week. If there is no increase, then we might think that this is probably due to an old infection or a carrier state which is persistent. So thus important to remember that the sensitivity and specificity of viral tests as compared to the cultures they aren't much. Okay, coming briefly to the treatment of salmonella typhi, this is important because patients coming with undifferentiated fever, patients coming with fever of unknown origin, they often have a diagnosis of enteric fever. So usually when a patient presents with fever, depending upon the seasonality of fever, and the patient is typically having high grade fever, depending upon the seasonality, we might suspect conditions like leptospira, malaria, dengue, scrub infection, influenza. And the sixth diagnosis commonly is this enteric fever. So enteric fever comes within the 6 common causes of fever with which the patient presents to the OPD or there in the inpatient ward. So normally, leptospira, malaria, dengue, they can be easily ruled out. The results, they are typically there within 1 day. So once we have ruled that out, and also scrub typhus, influenza, we send a swab test. What we are left with after ruling these 5 other conditions is usually enteric fever. So in our country, again, since enteric fever is very common, so we often institute the treatment for enteric fever after the initial battery of tests, they are negative. So it is important to remember that empirically, what do we start with? Typically, ceftriaxone is started. The typical dose of ceftriaxone normally is 1 gram twice a day. Ceftriaxone, typically a higher dose may be used. So typically we use 2 gram per day, though in books and in some literature they talk about that even 2 gram may be effective. Okay, but that is for fully susceptible individuals. As we would see that bacteria which are not that sensitive to existing antibiotics, they might require higher dose. So typically the ceftriaxone dose used is 2 gram per day. Another alternative is azithromycin 1 gram per day. So again here the dose of azithromycin typically which we use for CURI, bacterial tonsillitis, is 500 milligram OD for 3 to 5 days. But here again the double dose is used, that is 1 gram per day. So this is the empirical treatment. Now depending on the culture report, if it is fully susceptible, we might choose between ciprofloxacin, amoxicillin. Cotrimoxin may also be used. Chlorphenicol is typically out of vogue. For enteric fever, which is caused by multi-drug resistant organisms, so it means, as the name suggests, that the bug is resistant to a number of drugs. So typically what we use is ciprofloxacin, ceftriaxone, azithromycin. So here we would see that the dose is higher. Ceftriaxone, it's 3 gram per day, so typically we use 4 gram per day. And azithromycin may also be used for multi-drug resistant, NARST or nalidixic acid resistant salmonella typhi. It means that those enteric fever, those organisms which are resistant to quinolones, they are again treated with ceftriaxone and azithromycin as previously, or a higher dose of ciprofloxacin. So as compared to 500 milligram per day, we are giving it as 750 milligram twice a day. So 1.5 milligram in a day, right? And typically the duration for enteric fever is between 1 to 2 weeks, except for azithromycin, which is usually 5 days. Is there any role of steroids? Yes. So this is a condition where this is a condition of bacterial infection where steroids are used. So steroids, we know, is a drug which decreases the immunity. It is also a drug which decreases the inflammation associated with infection. So typically steroids are not used during bacterial infection. So suppose if a patient has a urinary tract infection, there's an infection which goes inside the patient's body and the patient is mounting an inflammatory response to it. So typically we won't use steroids. Antibiotic is all that is required. But however, if the infection due to a particular organism, in this case enteric fever, if the inflammation is out of proportion to the infection, and the inflammation is itself causing more damage to the body than the infection per se, then that's a scenario where we might choose to tone down the inflammatory response of the body. So that is where steroids are used. Dexamethasone is typically used in this dose. What is more important is for you would not be the dose, but the fact that remember that steroids can be used in conditions where the patient is sick. So typically, when there is neurological involvement or myocarditis, steroids are used. How do we treat carrier? Carrier can be treated either with cotrimoxazole or ciprofloxacin, and this is usually done for an extended period, 4 to 6 weeks. It's usually done. Now, what is also important is carriers once identified, they should be excluded from activities including food preparation and serving, and food handlers, cooks, chefs. Right? They should not be allowed to resume their duties until there are 2 or 3 cultures which are turning, sterile, at least one apart. And VI antibodies, the other antigen we was talking about, the polysaccharide antigen within the typhoid organism, they are often used to identify carriers among food handlers and in outbreak situations, because these antibodies are very high in chronic carriers. Is relapse common? Yes, relapse is common. We see it in around 10% of patients. Say these patients have enteric fever. When they are treated with ceftriaxone, they become better. They go back to their house. Now they come back. So within 2 or 3 weeks, complaining of similar high-grade fever. So it means that there has been a relapse. So it means that the organisms which were there, say in the reticular endothelial system, they have not been taken care of by the antibiotics. So the implication is the patient would require more antibiotics. Typically what happens is that, as I said, apparent recovery followed by relapse in 5 to 10% of patients. The culture may be positive after 1 to 3 weeks of defervescence, and the symptoms and signs reappear. As it suggests that the bacilli have not been completely removed. In some cases, relapse they occur more than once. Now, the prognosis of enteric fever, especially when antibiotics are started early, is good. Fertility is less than 1%. Typically, it occurs due to intestinal perforation, hemorrhage, myocarditis, but they may be higher in extremes of age. They may be higher in, serious complications. As I said, around 1 to 5% of patients they become chronic carriers. So this is it. I finished early because there was. So when there's a live class, there's more amount of discussion. There is, the dissemination or the discussion is much better. So this is a different medium, but I hope that you have received, some amount of information which would egg you to open your book once, perhaps today or tomorrow, say Davidson or Harrison, and just leaf through the basics of enteric fever. This is a very common disease. No matter where you are, what you're doing subsequently, you are going to require minimum knowledge about enteric fever. And this is also an important topic for your exams, both professional and MCQ exams. So I hope that you would, go through this particular topic, read it from a book, so that whatever you have discussed today, it becomes embedded in your mind. So that is all from my part. If there are any other questions, you can email it or get in touch with me. I'll be more than happy to discuss them. Thank you so much.